A 50-year-old male presents with a persistent dry cough and mild back pain. I am showing you his frontal chest radiograph and a T2 weighted thoracic magnetic resonance imaging scan. Describe the findings.
The frontal chest radiograph demonstrates a well-defined subcarinal mass that splays the carina and causes lateral convex bulging of the azygosophageal interface. The corresponding thoracic magnetic resonance imaging scan confirms a solid, well-defined mass in the subcarinal region with intermediate T2 signal intensity, similar to skeletal muscle. There are no internal vascular flow voids or fluid like high signal intensity.
Based on these imaging findings, what is your differential diagnosis for this subcarinal mass?
The main differentials to consider are subcarinal lymph node enlargement, a bronchogenic cyst, and left atrial enlargement.
How does the magnetic resonance imaging help you differentiate among these three possibilities?
Left atrial enlargement is excluded by the absence of vascular flow voids. A bronchogenic cyst typically appears as a thin-walled fluid structure with very high signal intensity on T2 weighted images and no contrast enhancement. The intermediate signal on T2 and solid nature of this mass are most consistent with subcarinal lymph node enlargement.
If I tell you the patient has a history of a nephrectomy for renal cell carcinoma 3 years ago, how does that affect your diagnosis?
With that history, the subcarinal lymph node enlargement is highly likely to represent metastatic disease from the known primary renal cell carcinoma.
Name several other extrathoracic primary malignancies that commonly result in metastatic intrathoracic lymphadenopathy.
Other common extrathoracic primaries include breast cancer, malignant melanoma, and head and neck squamous cell carcinomas.
What are the common non-neoplastic causes of mediastinal lymphadenopathy?
Non-neoplastic causes include infectious diseases like tuberculosis or fungal infections, and inflammatory conditions such as sarcoidosis and Castleman's disease.
Describe the normal radiographic appearance and anatomy of the azygosophageal interface.
The azygosophageal recess is formed by the invagination of the lung parenchyma into the posterior mediastinum, behind the heart and esophagus. Radiographically, it normally projects as a straight or slightly concave vertical interface.
What other pathologies can cause lateral displacement of the azygosophageal interface?
It can be displaced laterally by posterior mediastinal masses, esophageal tumors, hiatus hernia, bronchogenic cysts, and left atrial enlargement, projecting as a convex interface.
State the preferred minimally invasive diagnostic procedure to obtain tissue from this subcarinal mass.
The preferred procedure is endobronchial ultrasound guided transbronchial needle aspiration, or EBUS-TBNA, which allows direct cytological sampling.
What is a critical safety warning regarding the biopsy of a renal cell carcinoma metastasis?
Metastases from renal cell carcinoma are characteristically hypervascular, which carries a high risk of severe bleeding during transbronchial biopsy. Radiologists must immediately recommend thoracic oncology referral, suggest staging computed tomography and brain magnetic resonance imaging, advise pre-procedural planning noting the bleeding risk, and check for signs of hemodynamic instability. Refer to thoracic oncology and pulmonary medicine